Guys, welcome back to my channel. Thank you so much for tuning in. This is episode 3 of my weekly Q&A series. If this is your first time with me, this is a weekly series where I answer the most common asked questions through my Instagram and YouTube. And so if you have questions you want me to answer, make sure you comment below or follow me on Instagram and comment on my latest post, and I will try to get to as many questions as I can in these weekly series. And of course, I have a guest of honor today. This is Ozzy, short for Oscar De La Renta, and he really wants to sit here right now on my comfy green chair, so he's going to join us. The Q&A today are questions about residency and things that I'm doing right now. So question number 1, as a resident, do you wear a white coat in the hospital? This is a question that's going to basically depend on the rotation that I'm on. We definitely get white coats in the hospital. When you're a medical student or a dental school student, your white coat is shorter, so it goes to like your hip. That's to indicate that you're a student. And then they are long coats that go down to your knee when you are already a doctor. So if you're a resident, then you get a long coat. And I have multiple long coats that I'm given every single year in the hospital, and they actually dry clean them for us if we want, in order to make sure that they're nice and clean. I encourage you to try to dry clean them as often as possible, which is why my hospital dry cleans them for us. But to answer your question, it really depends on the service that I'm on. When I'm on a surgical service and I'm running around between the floors and the ORs, I don't often wear my white coat. Can't wear a white coat into the operating area. I have to be just in the hospital allocated scrubs. So it's hard to put on a white coat, take it off, put it on, take it off. I've lost my white coat a ton of times that way. Or a lot of times when we round in the morning on our patients and when we round with attendings, a lot of attendings do like for residents to wear their white coat because I think it looks a lot cleaner, it looks more formal. Patients have, have trust in their providers when they look polished and put together. So a lot of times over our scrubs that are kind of wrinkled and not necessarily super presentable, we'll put on a white coat and button it, and then that way you kind of like look like you're put together. I have read some studies about whether or not patients have more trust in their provider if they have a white coat on in general, and the answer was actually yes. Patients tend to do better with providers who do wear white coats, so that's kind of interesting. Some services that I'm on, like surgical oncology, tends to be a little bit more formal, so I wear my white coat a lot more on that service, but then things like trauma service and things like that, I never ever wear my white coat. And most commonly, actually, you'll see if you follow me on Instagram, a lot of times when I'm recording certain tidbits in the hospital, stuff like that, I'm actually in my little like cozy Patagonia sweater jacket, and the reason why I'm in that is because it's just like super cold in the hospital and you need pockets for storage, like pens and stuff like that. And so I'll more often wear my Patagonia jacket that has like my hospital emblem and my name and stuff like that more than I'll wear my own white coat. So that's to answer that question. The other question is, what are your duties as a surgery resident rotating on anesthesia? So actually, oral and maxillofacial surgery is one of the only specialties that rotates as long as we do on anesthesia. So I'm doing a total of 5 months of anesthesia, 3 months of adult anesthesia, and 2 months of pediatric anesthesia. That is more than anyone else in the hospital, and other than anesthesia residents themselves, we are the only specialty that does our own, that can pull our own drugs, do our own IV sedations, and we're able to do our own sedation basically, essentially. No other specialty really does that other than anesthesia. And so we're super, 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 super lucky that we have this wonderful relationship with the anesthesia department, and they take us under their wings. I have this privilege of being able to learn how to do anesthesia so that in the future we could do our own IV sedations. So my duty as a resident on anesthesia is initially the first month you're really just learning. You get paired up with a lot of CRNAs and you're learning how to intubate and do the whole case. You're learning how to do MAC sedations, you're learning, or MAC anesthesia, you're learning how to do general anesthesia, all sorts of different anesthesia. And then by towards the end of your rotation, you're actually expected to run your own room. So you'll be paired up with an attending when you'll do everything. You'll intubate, you'll administer the all of the drugs and be able to run your own case. And then the anesthesia attendings obviously will like rotate through the different rooms. And so it's a really fun and exciting opportunity for us, and you learn as much as you want in anesthesia. And so if you're really motivated and you're super interested, then you're able to do more, like, you know, with most things in the hospital. And so it's a really, really wonderful opportunity, and I've enjoyed it so much this year. All right, the third question is, how do OMFS surgeries happen on intubated patients? This is such a good question. To whoever asked this, is such a good question. Obviously, a lot of patients that get intubated through the mouth, and so you put an ET tube down through the trachea in order to ventilate them when they have lost their respiratory drive and they've essentially become apneic because they are, you know, either on inhalation anesthetics or they're, you know, getting IV drugs like propofol that are making them apneic. And so that's how you secure the airway, make sure that they're put on a vent and they're able to breathe. So how do you have a tube down someone's mouth and then you're working on their mouth? Obviously very complicated. So one way to actually get around that is nasal intubation. The same exact tube can go in the nose, believe it or not, and we'll get to it because it's a similar pathway, and we'll go straight down into the trachea. So I've done a couple of nasal intubations that are very, very difficult because you have to angle the tube, and then you have to get your McGills, these long forceps, to be able to redirect the tube, because of course it's going into a different pathway. Have a traditional ET tube going down the mouth if we're doing things like extractions, and we can just work around them. So that's the different scenario for a intubation on a patient that we are doing oral maxillofacial surgery. Head and neck cases, we will also do our own trachs, and so if the person is getting a neck dissection or getting a really large cancer resected, then a lot of times we'll do a trach as well. And so they'll start out intubated and then we'll switch it over to a trach. And so that's the alternative of also all of that. But obviously that's super invasive and only indicated for a very small population of patients. But that is an excellent question. So thank you to whoever asked that. And that concludes this week's episode. Those are the 3 different questions that I got that were somewhat related. So I decided to answer them in this video. Don't forget, you guys, to subscribe to this channel. Don't forget to like this video, comment below, let me know what other questions you have for me, and follow me on Instagram at 15blades for daily posts like this and more. I'll see you guys next time. Bye.